Hello, everyone. Can everyone hear me okay?
Yep.
Yeah, good. Welcome to this week's ECVIM lecture without border. I know many of you are our returning audience. We hope you all enjoyed our previous lecture. Like last week, our lecture today already has over 2,000 people around the world registered from various social, cultural, and professional backgrounds. We are also so excited to welcome our new audience who just joined us today. Welcome, everyone. We feel very thankful about your trust and support. As members of ECVIM, we are very proud of what we have achieved and what we are doing right now. Every day, we feel like one step closer, to the ECVIM's ultimate goal, which, if you know, is erasing pathology border around the world and make digital pathology easier to access. I think last week, many of you, let me see if we can.
Hello?
Oh, can you hear me now?
Yeah, the audio cut out for a moment then.
Oh, where does it cut out? Is it
20 seconds ago.
10 seconds ago? Okay, I just meant, can everyone hear me now? Yes? Yes? So I would just like to use about 2 minutes to introduce about what is ECVIM is. So ECVIM was founded by a team of social scientists, computational pathologists, and the computer scientists who are specialized in medical image analysis. However, we started to realize that our work on the state-of-art technology development can only benefit a very small number of people. Doctors, patients in remote and resource-limited area, those who are desperate for digital pathology solution to save life, unfortunately, can only a few of them can access or cannot access this very advanced technology and resources because it's just too expensive and also need a lot of supporting resources. So therefore, we founded ECVIM and hopefully hope to find a solution to address both the human resource challenge and also the equipment challenge. Yeah, so that's our solutions, except our affordable ECVIM whole slides scanning system and our digital diagnostic platform. We has been working on many educational programs, including these lectures, and also have a very popular retired equipment back to shine program, where we donate and rehome life-saving equipment such as microscopes and scanners to remote and resource-limited area. So please feel free to let us know if you want to donate any of your working equipment that is collecting dust, or if you think your organization really need any particular equipment, just let us know, and you can find more information on our website. And we also would like to thank our ECVIM Future Vet Pathologist Club team, which is led by Mr. Blessing Oyule. Thank you, Oyule. Together, we wish to support veterinary medicine students and also professionals to explore more interesting topics and be inspired by the top professionals and talent all around the world with also the border restriction. Yeah. Okay. So during lecture today, everyone will be muted, and can I ask please act professionally and respectfully. In the second part of this lecture, we will hold a Q&A session, and please leave your question briefly, clearly in the chat box. And you can click the raise hand function. Yeah, if you know in the Zoom, there's this function and you might be selected to ask questions. So I think from our last week's experience, we did manage to answer over 40 questions, but still did not get chance to go through the rest over 100 messages. So if you have any question, I do encourage you to leave your question during the lecture instead of leave it to the very end. Yeah. And also there are 8 poll questions, so get ready to answer them during the lecture. And this lecture is also, we're also holding a live stream on our Twitter account. So during lecture, if you have any access problem, you can go to our Twitter account to watch it as well. So this is our contact information, our website, exval.com, and also we are very active in the Twitter and LinkedIn. Okay, thank you. 2 more important things. Yeah, so please do not leave anything that's unrelated to this lecture, and also advertising, spam, and most importantly, don't leave your personal contact information there, like your email. Your attendance already being recorded when you log into this Zoom classroom. Yeah, and also as many of you may know, after this lecture you will receive a certificate of participation, but you can only receive it after you stay with us longer than 30 minutes. Yeah, okay. Okay, so today we are very honored to have Mr. Fergus Allerton with us to give us a lecture about the rational antibiotic use in cats and dogs. Mr. Fergus Allerton is a European veterinary specialist in small animal internal medicine, working at Willows Veterinary Center and the Referral Service in Solihull, UK. His main clinical interests are in the gastroenterology and hepatology, immune-mediated disease, and the antibacterial stewardship. He is currently chairman of the Small Animal Medicine Society, and also currently edited the latest edition of the British Small Animal Veterinary Society formulary. So in this lecture, Fergus will kindly discuss some rational use of the antibiotic in small animals medicine, important questions including when antibiotics are necessary and how to optimize the antibiotic selection, and how to share this information, this message with colleagues and the clients. Yeah, so let's welcome Fergus. Thank you very much. The stage is yours.
Thank you very much. So I have changed since that photo was taken. The effects of lockdown are quite, I think, obvious on my hair. Anyway, I'll now try and share my screen. So hopefully it will pick up the PowerPoint. I'll just switch to that. Bear with me a second. And if I just move that out of the way, I can launch this. So thank you very much for the introduction, and thank you really for this opportunity to speak. I'm really impressed with the international flavour of the audience, and I really hope that some of the subjects that we cover today will be useful to people. Please do put your comments in the chat, and I will try and get to as many questions as I can at the end. Thank you for the kind introduction. My name is Fergus Allerton. I work at a specialist small animal practice in the UK. My interests really today, I'm going to be focusing on antibiotic stewardship, and that is something that I've become passionate about in the last couple of years, largely through my involvement in the Protect Me project, which is something I'll talk about in a moment, but is a way to encourage rational antibiotic use in cats and dogs. So I think everyone who every clinician is somewhere on this spectrum of antibiotic use. So you'll find that some people, and you'll probably know colleagues, will use with, and so they will use them very frequently, cautious, and they will today is to encourage you to really think carefully each time you reach for antibiotics, so that you will only use them if you feel that there is a justified need. And hopefully that will mean that each time you use them, they will be effective, and importantly, we will reduce risks of adverse effects of using antibiotics unnecessarily. So I'm going to try and launch a poll now. So this should be poll 1, and I'm just interested in knowing what type of veterinary work the audience are doing. And so if you could indicate whether you're involved in large animal work, do you see cattle, do you see horses, are you working mainly with small animals like me in cats and dogs, and are you maybe not yet working with animals? So really, when I've graduated, I did 6 years in mixed practice. I loved the farm side, and would have stayed in that if my wife had allowed me to. But in the end, I've opted to do small animal work, and that's been the focus of my interest for the last nearly 10 years. And so there we go. Majority of people are doing small and large animal work, but a predominance of small animal work. So hopefully what I will be seeing and what I'll be talking about today will be relevant to the majority of people. So let's just, thank you for that. So let's move on. What are antibiotics and why are they important? Well, we're all familiar with antibiotics. We know that they are very helpful in treating bacterial disease, and they've made a massive difference to mortality rates. Now, this graph is actually a graph of human mortality over the previous century, and it's for United States of America. The data really relates to the United States of America only. I don't know what these extra lines are. This is the chart that shows deaths secondary to infectious disease. And you can see that over the course of the previous century, there was a steady decline in deaths attributed to infectious disease. And that's not just due to antibiotic use. In fact, antibiotic use didn't start really until the 1940s. It also reflects greater improvements in sanitation, availability of vaccination, things like that. And I have highlighted the 1918 influenza pandemic, which was a global phenomenon, similar to what we're all experiencing at the moment with COVID. And that killed a massive number of people. And interestingly, with that version of influenza, people didn't die of the viral challenge. They actually died from secondary bacterial infection. So if this discovery of antibiotics had been brought forward by 30 or 40 years, we may have been able to reduce this spike quite considerably and manage these cases more effectively. This picture is Sir Alexander Fleming, and he's commonly recognized as one of the founders of antibiotics because of his discovery of penicillin back in 1928. While he discovered it, it was actually these two gentlemen, Chain and Flory, who were able to recognize the potential of antibiotics. And they said, right, how are we going to use these in a helpful way? The first recorded use of antibiotics was to treat a London policeman who developed a abscess on his cheek, I believe. The myth is that it was secondary to a rose thorn, and he developed a really nasty systemic infection. Jane and Flory had managed to get a dose of penicillin, so they gave it to him, and it massively improved his clinical signs. But they realized that he probably needed a longer course of antibiotics, so they managed to recollect some of the antibiotics from his urine samples and things like that, and they managed to keep him going for a couple of days, but eventually he succumbed to that infection. The point really was that he provided proof of principle. He demonstrated that antibiotics could be used to save people's lives, and this was very important. And after mass production towards the middle of the 1940s, they became a vital tool in saving lives from infectious disease, in particular bacterial disease. What's important to recognize is that while penicillin is very effective at killing bacteria, bacteria don't want to be killed. And so they have developed mechanisms to protect themselves against the challenge of antibiotics. And these mechanisms vastly predate the use of antibiotics. In fact, I believe there have been studies of woolly mammoths and things like that from the Siberian permafrost, where they've identified some of these antibiotic resistance genes dating back many thousands of years. And certainly we know that bacterial penicillinase, which renders penicillin ineffective, had been identified in 1940 prior to the first use of antibiotics. This isn't a new problem. This is something that's been going on for some time, and we can consider it something of an arms race, i.e. we develop a new antibiotic, bacteria will rapidly develop resistance mechanisms to fight that off. So let's see if I can get the second poll going. So I'm interested to know what impact you think antimicrobial resistance could have on human health. So as we are developing more, and you can put more than one answer to this question, by the way, as we are developing greater bacterial resistance, we're encountering it all the time in our professional lives. What difference does it make? What cases are we seeing, and how is it going to affect our health? It's important in animals, but what impact could it have in people? And it's good to see that a lot of people are recognizing some of the really important and significant concerns with this threat. And it is potentially an apocalyptic threat to human health. And I think we are in the midst of a very serious global phenomenon, and seeing a tragically large number of people who are being affected by this viral disease. But I do fear that this is just an early warning of the other sort of health challenges that we will be facing in the years to come. And antimicrobial resistance represents one of the most serious ones that we are going to see. And I would say that, yes, unfortunately, we will see increased mortality. I'll talk through some of the numbers of that in a moment. You won't be able to have chemotherapy. If chemotherapy reduces your white blood cell count, it renders you at high risk of an infectious disease. So you need to be able to reach for antibiotics that are going to be effective and are going to protect you in those situations. So if all bacteria were resistant to those antibiotics, chemotherapy would no longer be available, no longer be an option. Similarly, routine surgical procedures could become too dangerous to perform. If you need a hip replacement, if you need surgical repair of your orthopedic disease after a significant trauma, these are situations where you could end up with very serious secondary infections, and we might not be able to take you to those surgeries if we can't protect you afterwards with appropriate rational antibiotic therapy. And this will automatically incur significantly increased healthcare costs. So that's the results that we got. I'm very pleased to see that, yes, these are going to be serious ramifications from antimicrobial resistance. And let's look at that in a bit more detail. This is a report that was commissioned by David Cameron, one of our former prime ministers, and it was run in December 2014. And roughly at that time, they were estimating that 700,000 people would die each year from the consequences of multi-resistant bacteria. And unfortunately, this is disproportionately picked up by developing countries. So countries in Africa, countries where the access to antibiotics and second-line antibiotics may not be as strong. But if we think that that's currently representing 700,000 people, by 2050, so 30 years' time, just within one generation, they are anticipating that 10 million people globally will die each year due to antimicrobial resistance. And to put that in context, that is greater than the number that die currently from cancer, diabetes put together, the two major killers, or two of the major killers currently. This is the population of Sweden dying every year, and we can't ignore that. We have to recognize that is a significant threat to people. And they do reckon that that will, unfortunately, 40% of that number will come from the continent of Africa. And why is it coming? Where does antimicrobial resistance come from? What drives this phenomenon? Well, one of the main drivers is antibacterial use, because it creates an environment that selects those bacteria with resistance mechanisms. When Sir Alexander Fleming was awarded his Nobel Prize for Medicine, he stood up and he said, well, thank you very much for this prize, and I'm really grateful to be able to provide the world with antibiotics, and particularly with penicillin, but I must caution that we don't use this inappropriately. And he'd already seen that if we go using penicillin unduly or to greater rates, we increase the risk of developing antimicrobial resistance. And he highlighted that warning back in, I think that was in the 1950s or 60s. And it's still very important today that we recognize that if we use antibiotics excessively, inappropriately, either in ourselves or in our patients, we are aggravating and potentiating the problem of antimicrobial resistance. And a good way to demonstrate this, and I hope this video is going to work in a moment, is to show what happens on a Petri dish. So in America, everything is bigger, so everyone, especially with an interest in pathology, should be familiar with a Petri dish. This is an American-style mega Petri dish called the mega plate, and this was designed at the Kishoni lab in Harvard. And this is freely available online. You can download this film and the information about it whenever you like. But what they did is they created this mega dish, and they put different concentrations of antibiotics across the dish. So you can see at both ends, there's no antibiotics, and then there's increasing, logarithmic increases in antibiotic concentration across the plate, peaking in the middle at 1,000 times therapeutic concentration. And then they're going to inoculate the plate with bacteria. So they put bacteria at both ends of this plate to see how they grow across this plate. And this is time-lapse photography, and it happened actually over 11 days. But you can see that the bacteria are quickly going to spread across the zero, the no antibiotic concentration. And then you can see, right, there's the arrow there. That's the first bacteria that's broken through into the antibiotic concentration. That's now resistant, so it can spread across that plate. And you can see that doesn't happen just once, it happens multiple times. So those mutations are occurring, allowing the bacteria to spread across the plate. And now they reach the second line, but this time the delay, the hurdle that poses is much less, and even less so by the third line. And you can see that now these bacteria have developed mutations and mechanisms through which they can survive perfectly happily in extreme concentrations of antibiotics. So if you now had a patient with bacteria taken from the middle of this plate, you're going to find that your antibiotics are completely ineffective. And that's taken 10 days. It's an artificial situation. And they calculate with each time. You can see how the E. coli can spontaneously develop in to treat an infection. A start those actually using antibiotics treat the majority of cases. That's a bad example of inappropriate. And this is where vets come in. More antibiotics are helpful than
Oh my God, seems Fergus is disconnected. Should we give him a few seconds, 1 minute to reconnect it? Thank you for your patience. Meanwhile, if you have any question, please feel free to send it either to me or to the ECVIM doc, so we can collect your question and to be answered at the end of this lecture.
Sorry about that. I hope that, I don't know quite where people dropped out from that. Hopefully not too long ago.
No, not too long ago. Don't
okay.
worry. Yeah, don't
Good.
worry. Thank you.
Okay, apologies for that. I don't know why. We've had a bit of a storm outside, so it may be that that's influencing this connection. What I was saying is that as vets, we are very that every time we use antibiotic, we want an effective and helpful medication, because if we use them unnecessarily, we risk losing potency. And in the UK, in the EU, is now banned, but it is still used across the world. And I think that's something that we have to think very carefully about. Is that an appropriate use of antibiotics? And we want to get
Hi, hello, Fergus. Sorry to interrupt you. I think the connection is still not very good. Can you hear us?
I can hear you very well, yes. Can you hear me?
Turn off the video. So do you think turn off the video or something like that will be helpful?
I can do that. Yeah. Is that better for you? Can you hear me again?
Yes, I think now a little bit better. Yes, thank you.
Okay, so I'll try without the video. I think that's probably an advantage to everyone anyway. So antibiotics resistance is a problem, but we shouldn't underestimate the importance of antibiotics, and we are still in a situation globally that more people will die needing an antibiotic than will die due to AMR. So do take on board the importance of using antibiotics appropriately, but don't ignore the fact that they are still a very useful, a very important medication that can save lives. And given that there are still very seriously large numbers of children dying from infectious diseases may be an issue with that is going to be that first line available, because we use those antibiotics inappropriately in healthy animals and ourselves, in effect, only people. How can we tackle the antimicrobial? An improved knowledge and understanding of antimicrobial. The more people know about it, the more they talk about it with their friends and colleagues, we can hopefully address this problem. Awareness is the first try, and we want to make sure that as a
I'm very sorry. I think we lost him again. Thank you for your patience. I know at this very difficult time, we all have to work from home. So the internet may not be very stable. So probably we can take this time to think about your questions so far. Yeah, your question related to this topic and any related advice that you might want from Fergus. So let's wait. Yeah, I think he's here. Hello, Fergus.
We're back again. I hope you can hear me. Can you hear me okay?
Yes, now we can hear you okay. Yes, yes.
Okay.
Sorry about that.
I think it's my internet this end. I do apologize. I don't know why it's quite so.
Yeah, it happens. I think recently in the UK, the internet is not very stable. So sorry about that, everyone.
No worries. Well, I should say that we've talked about antibiotic stewardship programs. That's going to be something I'll talk about in more detail in a moment. The other thing that we're keen to try and work on is to develop new antibiotics. The challenge with that is, how do you motivate pharmaceutical companies to make new antibiotics? Because you're going to say to them, we want you to develop a new antibiotic that's going to kill off our superbugs. And then you say to them, once you've developed it, we're not going to use it. We're going to lock it away in a cupboard, and we're going to avoid using it so that bacteria don't develop antibiotics. So there's no real financial incentive for the pharmaceutical companies to do this. And so they're looking at different ways and encourage it. We also need better diagnostics so that we can quickly identify people and animals that have infectious disease that need antibiotics. And we need to have these novel therapies, so non-antibiotic ones that can maybe reduce the requirement. Things like fecal matter transplantation, I'm really interested in that at the moment, that might reduce our requirement to use antibiotics in certain cases. This is the pipeline. It's a bit of an exaggeration, but really we've seen a lot of new antibiotics produced in the past century, but since the 80s, there have been few new classes of antibiotics that have become available to treat bacteria. So antibiotic stewardship, this is what I'm really passionate about, is recognizing and using the correct antibiotic for the right indication. You've got a diagnosis, you know what's wrong with your patient, and you know that it's got bacterial involvement. You want to make sure that this is used correctly at the right time with the right dose. There's no point in underdosing, and overdosing increases your risk of adverse effects. We want to use it by a route that it's going to be effective, using in a septic patient, you must give these things intravenously. Giving them subcutaneously, they'll probably sit under the skin and never get to where they need to get to. And you want to avoid causing harm to your patient. So make sure that these aren't going to, you don't want to be giving penicillin to a penicillin allergic patient. But for me, this is the last part is important as well. So you may feel, well, this antibiotic, I think it's got, my patient I think has probably got an antibacterial infection. And I know that they're getting the right dose and the right treatment. But think also about future patients, because if you use antibiotics unnecessarily in one patient, it may be that those same antibiotics are no longer effective when you come to use them in the future. And that might be a genuine bacterial infection and a life-threatening state in someone else. So other people in the future do impact on each decision to prescribe antibiotics. This is the Protect Me poster. Now, this is freely available online. If you put in Protect Me and probably BSAVA, which is the organization that came up with this poster, you can download this for free. If people want copies, just contact BSAVA and they will look to send them out wherever possible. We hope that this is a useful tool for people in working with small animals. This is purely a small animal version. There is one, again, called Protect Me that was produced for horses that is also available. And it highlights some of the key tenets, some options for specific conditions. So hopefully they would be, for example, and we'll go through a few of these in this talk. Within the poster, you could probably see these little black squares. These are QR codes. So if you do have, we can hopefully update it and get more information as we go along and improve the data that we provide as new studies, new work comes out to make sure that they are as accurate and informative as possible. And we always welcome feedback. There is a website, protectme@bsava.com. So if you've got any comments on the poster, we would welcome them and we would encourage people to provide company provides a lot of useful information, and the Danish group have produced antibiotic use guidelines that also offer excellent advice for a wide range of conditions. You will find all of these are free to download, free to access online, and I would encourage you to use these resources wherever possible to guide your antibiotic selection. I want to give an example now. This is a case that I saw a couple of years ago. A little dog, he was 4 months old at this time. You can see him bouncing around in the snow here. And he came to see me with a 1-week history of a cough, and he had no nasal discharge at the time. He was still eating well. He'd been growing nicely. He'd been regularly wormed. That's an effective treatment against lungworm, just in case you thought of that. So he was up to date with all his treatment, and he just came because the owner was worried that he'd been coughing for the last 7 days or so. So what would you do in that situation? What would you give Harry an antibiotic, and which antibiotic would you give him? So I'm interested to know those people that might reach for an antibiotic. He's only been coughing for 7 days, remember? Which antibiotic would you give him? Would you give him any antibiotic at all? I'm going to let that run for a minute if I can and carry on. So for me...
excuse me, Fergus, can you hear me?
Yep, I can hear you.
Yeah, I think you have to disable the annotation, disable the annotation on your side. So I think some of the audience are being naughty.
Do you know how I do that?
Like I see, somebody is doing it again.
Yeah.
So I think because we can't do it from our side, you have to do it on your side. So if you click on, I think more, I think there's option on more, and there's option to
disable attendee annotation.
Yes.
Okay, I've done that.
So. Sounds good.
Okay, sorry about that.
That's okay. It's not your fault. It's the somebody's really naughty.
Okay.
Yeah. All right. Then let's continue. Oh, can you hear me? Can you hear us? Oh, we can't hear you. Hello.
Can you hear me again?
Yeah, I can. All right,
Yep.
Cool, fantastic. Continue, please.
Okay. So I'm now stuck in the annotation, right? So, in answer to Harry, people have given quite a few good answers. I'm going to share the results now. So I'm with the majority here of people who would not give an antibiotic. And the reason for that is that Harry had only been receiving or had only shown clinical signs for 7 days, and he remained systemically very well. So I would say, while he may well have a bacterial infection, I don't think he requires antibiotics. And we know that kennel cough can be caused by Bordetella bronchoseptica. So yes, there is a potential bacterial involvement, but while he's well, let's not resort to antibiotics. And I think managing him without antibiotics is appropriate. Would I have reached for amoxiclav or doxycycline? Well, these are the recommendations for dogs where there are persistent signs, or if he'd been unwell, then yes, those are appropriate antibiotics to use. I would try and avoid a fluoroquinolone in a young dog. There is risks of cartilage damage in a developing animal, so I would try and avoid that where possible. And where do we get these recommendations from? Well, the vast majority of recommendations on the Protect Me poster came from ISCAID guidelines. These, again, are freely available to download. They've been published in the Journal of Veterinary Internal Medicine, and they provide recommendations for antibiotic use for a variety of conditions, including, in this case, respiratory disease, but there are also those for urinary tract disease. They were actually only updated last year. There's some for gastrointestinal disease. They're going to be coming out again, I think, next year, and for skin disease as well. Sadly, all these guidelines are eminence-based rather than evidence-based. What I mean by that is that they're a group of super specialists who've sat down and they've discussed what they would recommend. But unfortunately, they don't have much evidence to back up those decisions. And we can rely on their opinions, but it would be really nice if we could start building some stronger evidence to support their recommendations. But sometimes not using antibiotics doesn't work as well as we'd like it to. And this is Harry again. He came back because he still was coughing. And this is now 3 to 4 weeks down the line. He's still coughing, and I've lost the ability to get the polls. Where have they gone now? Bear with me 1 second while I just try and find the polls again.
Can you find it?
No. Oh, yes, it's back here. So I was just saying, Harry is still coughing. He's been coughing now for 3 to 4 weeks. What should we do now? Would you reach for another antibiotic? Would you say, now I am going to put him on empiric antibiotic therapy? Actually, he'd had a bit of that. Or would you do some further diagnostics? What's key to those diagnostics? How are you going to make any decisions about antibiotics in the future? what information would be helpful to guide that selection. And I think that these are all viable answers. There's nothing particularly wrong with any of these answers. You might say the owners may not want to do further investigations. You may not feel it's appropriate. So further empiric antibiotic therapy can be considered. I don't disagree with that. I think we have to be just aware that it's may not be as effective as we want to do, because we're still not sure this is a bacterial problem. So should we reach for a steroid trial? Well, he's a young dog, so I accept that we do sometimes see bronchitis and eosinophilic bronchopneumonia that could cause an allergic type syndrome, and he could be coughing for that reason. But I think that's maybe unlikely at his young age. So I think that would be brave, and especially as steroids have immunosuppressive effects, I probably wouldn't do that. So should we do some imaging? I think that's not a bad shout. And X-ray or CT, if you had access to it, are good ways to look at what's going on in his lung. What I'd like, and what I would really recommend, where possible, is to say, well, we think he's got an infectious disease process. We think it affects his lungs. Can we get access to these bacteria? Can we find them? And can we prove that they are involved in the pathogenesis here? So we might try and get a sample either via bronchoalveolar lavage or a blind tracheal wash. Because if you can culture the bug that's actually present, you might find it's a way to optimize your antibiotic therapy. So culture is a key component of antibiotic selection. And wherever you can get a sample, if you've got a urinary tract disease, you want to try and get a urine sample and send that off for culture. If you've got a skin disease, then can you get a swab from that sample? There are situations which may be more complicated. If you've got a concern about biliary disease and you think that there may be infection in the gallbladder, are you brave enough to take a sample from the gallbladder? So there may be situations which are harder, but for me, wherever you are anticipating using a long course of antibiotics, or where you're worried that resistance is potentially a problem, I would really try and collect a sample so that you know what you're treating. And if you're dealing with septic peritonitis and you see a dog that's come in with a belly full of free fluid, you want to start that treatment, but you also want to submit your sample so that you can make sure that your treatment is appropriate and that you don't need to increase it and use a different antibiotic, or de-escalate if there's only bacteria that can be covered by 1 or 2 antibiotics. This is what was done with little Harry. So he had chest x-rays, which were unremarkable, and he also had a lung wash performed. And on that, we grew, as I think everyone would have suspected, Bordetella bronchoseptica, a very common bacterial pathogen and a cause of an upper respiratory tract style cough in young dogs. So this is the culture, this is the profuse growth, this is the sensitivity testing, and this is important to look at as well. Which antibiotic should we select, and which antibiotic maybe should we not select? And you can see that for ceftiofur there's resistance. Well, in fact, all Bordetella bronchosepticas are going to be inherently resistant to. So that was this particular pathogen was sensitive to everything else, allowing us to choose whichever antibiotic we feel is appropriate. We want to now make sure that it's going to penetrate that site well, and so I would probably be reaching for amoxiclav or doxycycline. They would be my antibiotics of choice. Just to see if I can get my next poll up. And this is the next question. And what I'm interested in is, we actually decided to treat Harry with amoxiclav. How long should we treat him for? Should we give him 4 weeks? Should we alter it on clinical response? Should we repeat our BAL? Remember that you needed an anesthesia for that, and there's a small risk with every anesthetic procedure. Should we do it via thoracic radiographs? Is there anything else that you might use? Any other surrogate markers that could guide our selection of antibiotics? You'll find reference to these options in all the veterinary literature. So historically, if you suspected pneumonia and you had a positive culture on your lung wash, you would be using antibiotics. But I feel that's probably excessive, and I would be slightly concerned that we could end up with some I would therefore agree with the majority again here, that we should make this decision based on clinical response. If the animal is doing well, then let's good way monitoring response to treatment. C-reactive protein tends to be increased in most cases of pneumonia, and it goes down as that patient gets better. So if I was using that and I demonstrated that that CRP had normalized, I would probably only need a couple of days extra antibiotics beyond that. So I would use the clinical response, possibly supplemented with CRP. And yeah, it's nice to do thoracic radiographs, but they often lag behind the clinical improvement. So you may find that you need to treat for longer than is necessary. And antibiotic duration is one of those real challenges. We just don't have good evidence as to how long we should use antibiotics for in our patients. And that's a growing concern. I'm going to be running a study looking at different lengths of antibiotic use to treat sporadic cystitis in female dogs later this year, and I hope to provide some more information about that in the coming years. It is important to make sure that you treat effectively. Make sure that the antibiotic you choose is going to get to the site that you want to treat it with. If you have a prostatitis, amoxiclav is probably not going to actually penetrate the prostate and get to the bacteria there. You need to be using potentiated sulfonamide or a fluoroquinolone. These are instances where you need an antibiotic that will actually get to the area of concern. And if you can use a narrow spectrum product in the place of a broad spectrum product, you are again going to optimize your antibiotic use. So if you're treating a urinary tract infection and you have the option of amoxiclav or amoxicillin, I would encourage you to use amoxicillin. So that's going to be a preferable antibiotic choice in those situations. Here's the an antibiotic chart, and I would encourage people to use these things. They are again readily accessible, and think about your 4-quadrant approach to antibiotic use. So we have gram-positive and gram-negative bacteria, and we also have both aerobic and anaerobic bacteria. So you want to make sure whichever antibiotic you choose is going to cover the likely pathogens. So if you're treating a septic peritonitis, we are worried about the involvement of anaerobes. We are worried about the involvement of gram-negatives. So we need to make sure we choose a spectrum of antibiotic cover that will be effective against those types of pathogens. Back to respiratory tract infections. Really, for me, I would be using this is the recommendations. In Harry, we suspect he actually has, or we now know he's got Bordetella, so doxycycline would have been an appropriate choice of antibiotic. One situation where you may feel you need to use a different antibiotic is if they've recently been treated with, say he'd already been treated with doxycycline. While you're waiting for those culture results, you may need to choose an alternative antibiotic because you'll be worried that they might already be resistant to that particular drug. And I've mentioned already the duration of treatment and the use of C-reactive protein to guide that. Here's a different example. This is a comparison of two different patients, one canine, one human, and this is looking at who is likely to get an antibiotic. And this is a sad indictment of the use of antibiotics in the UK currently. If we take an 8-year-old West Highland White Terrier living in Birmingham, so a small breed of dog, and they present with a 3-day history of hematochezia, blood in the feces, which the owner reports is a recurrent issue, and they will often say, well, I came in before with this and one of your colleagues gave me antibiotics and he got better within 3 to 5 days. Should you give that patient antibiotics? And we can ask, SAVSNet is a surveillance network available in the UK. We can see how many vets would say yes to that. How many vets would give that patient antibiotics? We'll have a look. Patient 2 is an 8-year-old child living in Bangladesh, and he's presented with profuse watery diarrhea and moderate dehydration. And we know that several members of his family already have been diagnosed with cholera. And we can ask the World Health Organization what their guidelines would be to try and manage that situation. And actually focus their efforts on rehydration. And they would only resort to an oral antibiotic if the patient was severely dehydrated. And this is really interesting because there is some evidence that earlier instigation of antibiotic therapy will shorten disease course and reduce the severity of shedding of cholera, which is a bacteria. So there is a reason that you might feel that antibiotic use is justified in those cases. And so I did write to the World Health Organization about these recommendations, and they said there are a number of reasons that they would advocate avoiding antibiotics in these situations. And the most important one for them was the antibiotic stewardship. If they use antibiotics for every patient, they probably wouldn't be in a situation where they had antibiotics for the patients who develop resistance. So if you do get multi-resistant cholera, that would become a requirement for higher tier antibiotics that may not be financially viable. So this is a real challenge. And an example of when antibiotic use is being dictated by a fear of antimicrobial resistance. And this has not translated to the UK because when the University of Liverpool ran this study, what they found was that if you looked at dogs that come into clinics in the UK and they have, say, acute diarrhea, as our hypothetical Westie had, 50% of times they will go home with a prescription of antibiotics. What percentage do we actually think is necessary? I'd be interested in your comments on this. How many dogs presenting with acute diarrhea have infectious disease? How often would you give antibiotics? Would you be using them each time you see these presentations? Personally, I would suggest that these are rarely significant infections, even when bacteria are involved, and the requirement for antibiotic is likely less than 5%. So I think this is an area where we could massively reduce our antibiotic use. Acute diarrhea is a common cause for presentation in small animal practice, and we shouldn't be resorting to antibiotic use unnecessarily. A cough is actually one of the most common examples of inappropriate use of antibiotics in humans, and something that leads to excessive and inappropriate antibiotic use in a vast majority of cases. So we want to try and make sure that each instance of using these antibiotics, we are sure that there is a clinical requirement. And acute vomiting, 20% of dogs that present for the first time, so they've had less than 7 days of vomiting, 1 in 5 go home with antibiotics. For me, that's only likely to provoke further vomiting, as I can't really think of a bacterial cause of acute vomiting, or not one that's significant. So I would be saying that these conditions are all examples where antibiotics are not necessary in the vast majority of cases. And so if we could try and limit our use of or recourse to antibiotics in these situations, we could dramatically impact and reduce antibiotic use. And this is another of the ISCAID consensus statements. They highlighted that the majority of bacterial infections are associated with self-limiting diarrhea. So they just don't need antibiotics. And as vets, we should be brave enough to say, no, we're going to concentrate on supporting these patients. We are not giving those animals antibiotics. And in doing so, we would reduce the risk of antimicrobial resistance. And this is just a paper that came out of the Texas GI laboratory and Jan Suchodolski's work. And he highlighted that you can look at the diversity of the bacterial flora, and you can say they've created this index based on a number of different bacteria that are present, where a healthy dog is down here. These are the healthy dogs. They've got a nice negative dysbiosis index. They made it negative for healthy dogs. And when they get chronic enteropathy, chronic gut disease, it goes up. So they've got a disturbed microflora and they have an increased dysbiosis index. Well, you achieve the same thing by giving an animal antibiotics. And this is an antibiotic that is commonly used to treat diarrhea, metronidazole. So these are healthy dogs. There's nothing wrong with them. They've got a nice negative dysbiosis index. You give them metronidazole, they jump up to a dysbiosis index very similar to a dog with chronic enteropathy. And those dogs haven't got chronic enteropathy. They've just been given antibiotics. And sadly, it can take 4 up to several months for that normal gut flora and nice diverse population to restore itself after a relatively short course of antibiotics. So do not consider these to be benign treatments. They will have disturbances on our patients, some that we will not actually see, but may have lasting consequences and can actually disrupt their health as well. These are data from Australia actually, and what they're looking at is how often vets would use antibiotics for simple surgeries. And so if you're doing a castration, it should be a quick and straightforward operation, and provided you maintain surgical asepsis throughout, there is no need to give antibiotics. And sadly, over in Australia, 20% of the time they're giving antibiotics for a castrate and up to 25% for a spay, so ovary hysterectomy. And that for me is vastly excessive. These numbers should be 0. Antimicrobial prophylaxis, surgical prophylaxis should be only in surgeries where we feel either there's been a compromise to asepsis, or they've lasted over an hour and a half, or their involvement, you've been opening a hollow viscus, such as the gastrointestinal tract. Then you can probably justify it. But in these type of simple, straightforward surgeries, we should be able to avoid use of antibiotics. Skip that. So, see if I can get my next poll up. Why do you think vets prescribe antibiotics so often in these situations? So if you don't think an antibiotic is necessary, I've given you various examples: acute diarrhea, acute vomiting, surgical prophylaxis. Why are we doing it? Why are we giving antibiotics as often as we are? I think if we recognize these problems and we hopefully discuss these with our colleagues, think about them carefully. We can, and there's multiple correct answers, by the way, here. We can hopefully limit them, because these are very common and very understandable. These experiences are not limited to vets. We know that doctors have exactly the same concerns. They don't want to be that person who misses a septic patient and delays their use of antibiotics, leading to nasty infectious diseases that kick off and cause all sorts of problems. They don't want to be the surgeon whose wound breaks down and ends up with a nasty surgical site infection. So it may be the easy option to reach for antibiotics and protect yourselves in those circumstances. But the easy option is not necessarily the right option. And for me, actually, this is a disaster. If you use antibiotics at the rate that we're currently using them, we are going to be in that apocalyptic state that's been predicted for 2050. It is our responsibility, our opportunity now to limit our antibiotic use, to be part of the solution and say, well, actually, surgical complications are really rare. Even if you use antibiotics, you may reduce your risk of a surgical site infection from 4% to 2%. But that's a tiny benefit. It's a minimal benefit given the large number of dogs that you'd be giving unnecessary antibiotics to. So do we really need to do it? When I run this survey in the UK, people often say, well, the owners are expecting this. That's what they've come in for. And they are adamant that their dog, their pet needs antibiotics. But we need to be the voice of reason. We need to say to them, actually, we're the clinician in this situation, and we have evaluated your pet, and we don't feel that antibiotics are necessary, and we're going to make a treatment plan that does not involve antibiotics. And get the owner on your side. The more they're aware, hopefully then when they go to the doctor and the doctor says to them, well, here's some antibiotics, they'll say, well, are those antibiotics necessary? The more people that are aware of this, the more times this conversation is had, hopefully the fewer times antibiotics will be used inappropriately, and the better off we'll be in the future. So that's really something I'm keen to do. Don't hesitate to mention that antibacterials are not a benign drug. I've shown you the effect on the microflora, but antibiotics can have all sorts of problems. They can cause retinal degeneration in cats. They can cause cartilage development abnormalities in young dogs. We know that potentiated sulfonamides can cause very serious problems in some, especially things like Dobermans. I would avoid potentiated sulfonamide in a Doberman at all costs because of the potential risk of severe immune-mediated complications. Occasionally, if you're using doxycycline, certain formulations of doxycycline have a very significant acidity and can cause esophageal irritation and stricture. That can be life-limiting in some cats. So think carefully, do we need to put that animal at risk, especially if they're difficult to tablet and they run off with that tablet stuck in its esophagus? They could end up with a much more serious problem than what you're actually treating. So antibiotics, they're not benign. Think carefully before using them. This study was performed in the UK, and they asked vets why they'd made those antibiotics decisions. And vets, when they were put on the spot, they always pointed the finger at the owner. They said, well, actually that owner, they insisted that I give antibiotics to that pet, and they forced me to make that prescription. Well, you teach to the same owners and ask them why their pet ended up with antibiotics. Often they will say, well, actually, it was the vet's decision and we would have happily not had antibiotics. So let's have the conversation in the first place. Let's discuss with them. Let's say to the owners, antibiotic stewardship is important. We want to reduce the risk of antimicrobial resistance. So I don't feel your antibiotics are necessary for your pet. Get them on board, make them understand why you're making those decisions. This is a relatively common presentation. So we've got a young female new to domestic short-haired cat with classic lower urinary tract signs, pollakiuria, hematuria. She's a bit uncomfortable when you palpate her abdomen, probably around the bladder. And she actually pees a small amount on the consult table, so you're able to demonstrate that she's got a bit of hematuria present there in a well-concentrated urine. So fair enough, you want to send it off for a culture, that's a reasonable thing, but should we give this cat antibiotics? Is it an appropriate example? We think she's got cystitis. Does she have bacterial involvement? Well, this age of a cat, chances of her actually having bacteria involved about 1 to 3%. So does she need antibiotics? I would argue no. I think I would explain to the owner, this will get better in 3 to 5 days. Let's make sure your cat is comfortable, give it appropriate pain relief. Let's make sure that we increase and optimize her water turnover so that we support the bladder as much as we can for the next few days. But let us not give this cat antibiotics. And if the owner argues and says, well, I think they need antibiotics, I would reach for this. This is the non-prescription form, and this is a way to have that conversation and to close these consultations, reassuring the owner that you have made a conscious decision not to give antibiotics. And advice, and we would put some safety netting advice there as well. So we would say, if your pet's not better in so many days, so probably 3 to 5 days in this case, or if there's new symptoms that appear, then please do contact us. Come back in and we'll re-examine and remake that decision. And this is a great tool. It's something that can help make that consultation flow more easily and avoid unnecessary antibiotic use. And we know that these work, not necessarily in veterinary medicine. Prescription of the human a prescription and they can go and cash it in, but they can't to go and get their antibiotics. So there's a time stamp on it that makes them wait, or that in this case, that they get better first. Or you can give them, like the example on the previous page, a non-prescription form. And we know that actually it doesn't make much difference. So there is no difference between giving antibiotics and delaying that use in terms of clinical outcome. That should be reassuring to us. We should be able to say, whether they have antibiotics or not. Patients actually do like to go home with their pot of antibiotics, so we have to reassure them that they are no worse off, because we achieve a massive reduction in antibiotics. If you give out antibiotics to all patients, it's obviously going to lead to much greater antibiotic use than if you don't give out antibiotics. And in reducing antibiotic use, you are going to help future generations. There are a particular class of antibiotics that I want to highlight that I think we want to really avoid as much as possible. And these are called highest priority critically important antibiotics. And this definition comes from the World Health Organization and also from the European Medicines Agency. And the ones that are relevant and you'll be familiar with are going to be the fluoroquinolones, so in particular enrofloxacin, marbofloxacin, and third generation cephalosporins. I'm not sure how many people use things like cefavecin. We have a drug called Convenia in the UK, which is a long acting third generation cephalosporin, and people are using that rather excessively at the moment. But these are the antibiotics that have got significant value to treat life-threatening infections in people. and they are ones that there is a growing problem of antimicrobial resistance. So these are the ones that if you can find an alternative, you should reach for that. Try not to use these medications in our cats and dogs and our cows and livestock as well, where possible. We know that currently in the UK, 6% of prescriptions in dogs use probably mostly fluoroquinolones, and up to a third in. These numbers should be less than 3%. And this is the convener that I mentioned. We have to be careful with this because it is a highest priority critically important antibiotic. It's one that we should be using have culture and sensitivity that backs up that antibiotic selection. But that's not where we're at the moment. So, type of antibiotic is because of ease of administration. But I would try and avoid doing so through reaching for an antibiotic like this. On the Protect poster, we had some traffic light recommendations, and there are certain antibiotics that we feel should be reserved for human medicine use only. So if you're seeing drugs like imipenem, vancomycin, and you're injecting those or administering those to your feline or canine patients, I would think very carefully about those. These are antibiotics that are really very, very important and valuable in human medicine. And I'm not sure that we can justify their use in our pets. And I would say, and I think it's maybe a harsh thing to say, I would say that these antibiotics should be restricted and should not be used in animals under any circumstance. The second tier of antibiotics, these are the HPCIAs, the highest priority critically important antibacterials that I've just been mentioning. These are ones that I think you should be able to use, but only if they're really necessary. So is there an alternative? Is there a first-line antibacterial that you could use instead? If so, don't reach for these. Limit these to specific circumstances where those are the only appropriate antibiotic. So for example, if you had a prostatitis in a Doberman, yes, fluoroquinolone would be my antibiotic of choice. Otherwise, can we find a more benign alternative? And that's what I would encourage you to try and do. In the, you can put you on the wall, but it may be that no one actually listens to anything that we're saying, and people will continue to use these antibiotics anyway. Well, in France, in Germany, and quite a few other countries now, they've made it a legal requirement that you can only use certain classes of antibiotic if they're supported by culture results. Probably the way that I would suggest this is run in instill to back up your system, where if you feel they're indicated, you chat to a colleague. You say, I'd like to use, it will say alternative antibiotic, and they will challenge you, and in doing so you will have greater confidence when you do resort to these type of antibiotics. one more case, just that I'd like to mention, is a little dog called Seth, and he had a history of chronic skin disease, and you can see he's a bright and active Springer Spaniel. He's running around, he's put his foot in a rabbit hole, I should think, and he's got a abrupt onset infecting his right hind and cruciate ligament rupture. So he has a tibial plateau leveling osteotomy, a TPLO performed, but it could have been any surgical procedure to repair that damaged stifle. But 10 days post-op, he comes back into the hospital because he's got a swollen and painful joint. And you can see that there is limited reunion. We've got a malunion here, and massive soft tissue swelling. And the joint was hot, it was very painful, and very obviously a source of concern for Seth. So what should we do now? Should we go back to surgery? Should we take him back to surgery? Should we give up? Should we chop off his leg? Or should we sample it? And if we're going to reach for antibiotic therapy, and I think that there's a high level of suspicion that we've got bacterial involvement here, what antibiotic are we going to reach for, and how would we manage that? So be ultimately a decision in some cases. Sensible approaches of arthrocentesis or further revisional surgery. I think antibiotic therapy is likely to be necessary, and I would have started empiric therapy in this patient while I was waiting for the culture and sensitivity results. But antibiotic therapy on its own, given that this dog has a history of chronic skin disease, given that this dog has had surgical intervention, to make sure that that therapy is appropriate. And this is what was done. Actually, they went in and they removed some of these implants and they sampled the joints. And can you find an antibiotic that would be effective for Seth? Is there anything that you would be comfortable to administer to him? So you can see that using these ones where there's resistance is not going to work. So beta-lactams are off the table. Gentamicin, only intermediate sensitivity, and gentamicin has nephrotoxicity, so you can only use it for up to 5 to 7 days, and given this intermediate profile, I'd be quite reluctant. Neomycin, very difficult to get hold of, so probably wouldn't go for that one. What else could we be considering? So, final poll. Is there an antibiotic solution to Seth's problem? Quite well tolerated. Make sure you squirt it down with a bit of water so that it doesn't get stuck in the throat. So yes, I think that's fine. Chloramphenicol. So yes, we did look into that, but it was financially prohibitive. Nitrofurantoin, not an effective option, I'm afraid. So I would not be selecting nitrofurantoin. If this was a urinary tract infection, that's when you reach for nitrofurantoin, because that's concentrated in the bladder and is an effective way of treating a lower urinary tract infection. But it has no efficacy whatsoever outside of those tissues. So that would have not been useful, and so I would argue it shouldn't even be included in the report. So if you were doing a report and you knew this has come from a stifle joint, I don't think they should be allowed to put nitrofurantoin on the list, because we know that its penetration will be poor. So I think these are cases that chloramphenicol, I would probably have agreed, yes, I would have gone for that as my treatment option. But unfortunately, it didn't really work, and you can see this isn't quite the same dog, but that's what happened. We ended up three-legged because we just weren't able to control the infection in that joint. This is Harry again. He did actually come back to see me, and he'd been treated for lameness. He was about 12 months old by this stage. He'd been treating for lameness, but had developed an abrupt loss of appetite. He was then hot and had abdominal distension, and we identified that he had free abdominal fluid, which we tapped and saw that he had lots of neutrophils and intracellular bacteria. So these are serious conditions. These are life-threatening conditions, and anything that can involve bacteria at that level could be deadly within a matter of hours. So these are situations where you need to instigate antibiotic therapy with broad spectrum as quickly as you possibly can. And there are various combinations, and in his case, we are immediately suspicious that given the non-steroidal use, there could be gastrointestinal perforation and leakage. So we want something that's going to be broad spectrum here, and we might go for something like amoxiclav and marbafloxacin. So good broad spectrum gram-positive and anaerobic cover from that part, and excellent gram-negative cover from the fluoroquinolone. So that's an instance where I might reach for that. You could have, instead of using amoxiclav, you could have used ampicillin and metronidazole, and instead of using marbafloxacin, you could have used a aminoglycoside. So those are alternative options. You could, I think in this situation, say, well, we're not expecting too much gram-positive involvement, so metronidazole and marbo would also have been an appropriate selection. And this is just one of the sections on the poster, and just for a bit of explanation, the red symbol here, the red Petri dish, is that we consider culture to be mandatory, because if you do identify a resistant bug, you need to know about it as soon as possible so that you can alter your antibiotic therapy accordingly. Within a practice, I would strongly encourage you to have a nominated antibiotic guardian. If you are interested in this field, if you think that antibiotic stewardship is important, then being someone who shouts that from the rooftop and encourages your colleagues to engage in this can be really, really important. And if you're working in a practice or in a university department, then I think it's an opportunity to guide that policy, to encourage people to avoid antibiotic use as much as possible. Monitor what you're doing. Look at where you're at the moment. Say, how often do we use antibiotics currently? Is there anything we can do to reduce it? And if we put these measures in place, where are we in 3 months' time? Where are we this time next year? Have we achieved a significant reduction in antibiotic use, or a change in that antibiotic use? Have we moved away from some of these highest priority, critically important antibiotics? That would be a real success, and something that I would encourage you to try and put in place. Can we adapt to local antibacterial sensitivity profiles? Well, if you find that you're constantly seeing resistant bugs, and every isolate that you test is resistant to amoxicillin, stop using amoxicillin. It's not appropriate. And if you start withdrawing that antibiotic from circulation, bacteria will become sensitive to it again in the future. So there's no point reinforcing an inappropriate antibiotic. Go on antibioticguardian.com. This is a global website and one where you can become an antibiotic guardian. This is my certificate, and I would encourage you to join this movement. It's an initiative that's encouraging people to take responsibility for their antibiotic use and their approach to antibiotic use in all aspects of human and veterinary medicine. So I would go on to antibioticguardian.com and become an antibiotic guardian. You'll see a wealth of useful tools that can help you contribute to this important movement. Share this message. I really hope that you can have seen the importance of antibiotic stewardship and the threat from AMR. Think carefully when you're prescribing. Is it your decision or is your client influencing it? And can we help by educating others to limit our antibacterial use as much as possible? I think education is one of the key components of any antimicrobial stewardship program, and one that we really want to encourage you to engage with. So these are the big wins. In my opinion, antibiotics are not indicated for acute diarrhea. I can't see any cases of acute vomiting when they should be being used, in dogs and cats at least. Nasal discharge is bacteria are not a primary pathogen, so they should not need antibiotics. Feline lower urinary tract disease, so it's just cats, because dogs do get cystitis more commonly, but in cats it's going to be stress related. It's not bacterial, so they don't need antibiotics. And antibiotics, actually, the act of giving them might be stressful to the cats, so it's not going to help. Little Harry, who had his upper respiratory tract cough, he didn't need antibiotics early on and shouldn't have got them. So do have these conversations at work. Do talk to colleagues about antibiotic stewardship and the importance of it. Feel free to download the Protect Me poster and do try the non-prescription pad if you can get hold of that as well. These are tools that we hope will be useful to you and will help you when you come to making antibiotic decisions to treat your patients. Keep asking the question, is an antibiotic indicated? Do we really need to use them for this particular case? Because if you don't, withholding them should have no detrimental effects on your patient, but will have a significant benefit in the global battle against antimicrobial resistance. Monitor, let's see how well you're doing. Can you make these changes and can you sustain them? So how often do you have to repeat the reminders to some colleagues who like to give out antibiotics for every case? Well, try and change their behavior patterns, but do so gently and respectfully, and hopefully we will achieve great things in the years to come. And do become an antibiotic guardian. Their Twitter feed is brilliant, and there are lots of people engaged in this battle, and hopefully they will encourage you to launch your own versions of antibiotic stewardship where you are. This is my final slide, really. So I introduced the spectrum of antibiotic use right at the start. I said that there are different approaches to antibiotics, and hopefully everyone will be somewhere on this spectrum, but hopefully you might be more cautious in your approach to antibiotics in cats and dogs and in farm animals, and even in ourselves in the future. There is a place for them. They are very useful. They do save lives. So I'm not advocating antibiotic avoidance, because there are situations where the earliest instigation of antibiotics, for example in sepsis, is crucial. Sadly, my aunt died of sepsis nearly a year ago, and she'd been to the doctor the day before and he'd said it's probably viral, and that she didn't need any treatment. One always wonders whether earlier instigation of antibiotics would have saved her life, because she did succumb to sepsis after spending 3 to 4 days in hospital. So there are situations where you need antibiotics and you want to get them soon as possible. So if you think there's an infectious disease, if you think bacteria are involved, let's use this super tool to treat that. But if we don't, if we think that there's maybe an alternative explanation for this presentation and maybe bacteria are not suspected, then let's find other ways to control those signs. So, and that's it really. That's everything I've got to say on antibiotics. I'm very happy to hang on here and answer any questions. I'll have a look at the chat and see if I can do that. I do apologise for my dodgy internet connection. I don't know why that flaked out quite as often as it did. I hope that there have been some useful points and some take-home messages from today's talk. If you've got any other comments, if there's any other subjects that you'd be interested in from a small animal perspective that you'd like to hear about, I'd be very interested to give further talks in the future if that would be useful. But thank you very much to everyone who's listened and for taking your time, and I'll try and answer some questions moving forwards. Thank you.
Hello. Hello, Fergus. Thank you so much for your talk. That was really amazing. Sorry about the story with your aunt. And yeah.
No, well, I'm sorry about my internet connection.
Oh, that's all right. So now we're entering the Q&A session, the exciting part. So we've collected quite a few of them, as you can see. Until now, there are about 31 of them, and we're not professional, but we try to group it into different categories. So hopefully they're correct. Some of the question has already been answered, so I'll just go through this, and with a mix of live questions. So the audience, if you want to ask a question, can raise your hand, and I will unmute you, so you can bring up your questions. So let's start with the first one, one of the earliest one, I think. So what is the adverse effect of
fluoroquinolones? In young dogs, there is a significant risk of impaired cartilage development. So people are very worried that if you give, especially to large breed dogs, if you give fluoroquinolones in those situations, they will potentially develop significant lameness and may have lasting mobility issues. So that was based on studies that performed in the 60s in beagles. I think there are situations where you will still use them, but we would try and avoid fluoroquinolones in any developing young dog, especially large breed dogs.
I see. That was useful. And the second one, is it safe to use ceftiofur sodium parenterally in dogs in severe respiratory distress? If yes, what's the protocol?
So I'm cautious to advise specific protocols, and I would always refer to the manufacturer's instructions and things like that. Cephalosporins can be used to manage respiratory distress. I guess you're suspecting in that situation a pneumonia. So if you believe it's a bacterial pneumonia, is it going to be an aspiration pneumonia? In which case, is the spectrum of activity of a cephalosporin sufficient? And I would be cautious in that respect. So I would probably be more likely to reach for a potentiated amoxicillin, such as amoxicillin clavulanate. If you suspect that the respiratory distress is due to Bordetella, then I would not use a cephalosporin because they're inherently resistant.
I see. And the third question, what's the effect of meat with lots of drug disposed on man, and can the affected meat be given to zoo animals?
So that's a brilliant question. And antibiotic residues are a significant risk to human health. Some countries have very, very strict withdrawal periods. So you cannot use an antibiotic and then submit that animal for slaughter for set periods, often well beyond the likelihood of that antibiotic being retained in that animal. So we are doing, those type of industries are taking measures to minimize our exposure to antibiotic residues in meat and milk, for example. And I would encourage you to do that because environmental exposure to antibiotics is the same as, so if you eat it when it's been injected into a cow, it's the same as taking the tablet directly, and it will influence your gut flora, and you will end up with resistant genes inside your gut flora. So those bacteria will now have resistance to certain antibiotics. That's probably not a significant problem. And actually, lots of us will have multi-resistant gut bacteria within our guts. They don't cause a problem there, but if they get out and you then develop a serious infection, that resistance mechanism can be transferred to a serious pathogen. So we want to avoid exposure, and I would try and ensure that any food, any animal that's going into the human food chain should not have any drug deposits in it whatsoever. The food can be given to zoo animals, and I guess if that animal was slaughtered before it is fit for human consumption, then people will likely use it for zoo animals, but it will have similar impact in zoo animals. And so it's not ideal. I guess it may be the lesser of two evils and we need to feed these guys, but I'm not sure it's a practice that I would encourage if it can be avoided.
I see, I see. Cool. So let's unmute some of those who raised their hands. Let's see who I should do first. Yep, Hassan, you are muted. Would you like to ask your question?
Can you hear me?
Yep.
Thank you, sir, for your nice presentation. My question is, if a patient comes to me after being treated by another doctor, and if the patient is not well recovered after using antibiotic by that registered doctor, how should I manage, or how should I approach the patient? The antibiotic is used previously by another doctor, but the patient is not recovered. How should I approach the patient? Should I use another antibiotic, or how should I approach basically the protocol? I want to know.
Excellent. That's an excellent question. I think that we see that quite a lot because I work in a referral hospital. So lots of the animals that we see have been pre-treated with antibiotics. I think I would go back to that original fundamental question. Are we dealing with a bacterial infection? So are the clinical signs that were present when the animal first became ill, are they consistent with bacterial infection? We see lots of pyrexia of unknown origin, and actually that is more commonly an immune-mediated disease with no bacterial involvement than it is true bacterial infection. So are we really treating a bacterial infection, yes or no? Can you sample it? Because if the animal's not getting better, chances are there's still a bacteria there that is active. So if it was an animal with a urinary tract infection, can you get a urine sample and can you look at it under a microscope such that you can demonstrate that there are still bacteria there? So you could actually prove that the antibiotic that's been used so far has not been effective. Can you culture those bacteria? And there are always challenges to culturing an animal who's been on antibiotics, but if you can see the bacteria, then there is a reasonable chance that you might still be able to grow them. So I would try and demonstrate the presence of bacteria. And then, yes, I would likely switch the antibiotic because you've got evidence of treatment failure. Make sure that that isn't due to compliance factors. Has the owner actually administered it? Is the dose been appropriate? Has it been administered via a route where it's likely to actually get to the bacteria that you're trying to treat? So as I mentioned with nitrofurantoin, great if you're dealing with a UTI, but if you're dealing with a different type of infection, a chest infection, say, it's not going to have any beneficial effect at all. So I think those are situations where you have to review the situation, and any antibiotic use should be reviewed regularly and adjusted accordingly.
So basically there are many options. Should we follow up at first? Should we do the CS test? Then we should give antibiotic. That should be the best option. Am I right?
Say that last bit again. Sorry.
After getting the CS test results, at first we should do the CS test result, sensitivity test. Yep. Then we should follow the treatment protocol. Is it safe, or is it the best for antibiotic if I suspect if I suspect bacterial disease?
That's the best approach, yes. I think you have to judge the patient. If you're really worried about him and you think, well, it's going to be 2 to 3 days before I get my culture results back, you do not need to delay. So it's not always that you're going to say, I'm not treating this patient for 3 days. You may have to jump in and change your antibiotic while you're waiting for those culture and sensitivity results. But if you have a stable patient with maybe a skin infection or something that you think this is likely to reflect antimicrobial resistance, then I would wait for the culture and sensitivity results.
Thank you, sir. Thank you for your answer.
Thank you.
Thank you. And let's unmute another one. So okay, that didn't work. Let's try this. Ahmad
Hello, good afternoon,
Shehu.
sir.
Yeah.
Yes, I'm Ahmad Shehu from Nigeria.
Hello.
Yes, I'm Ahmad Shehu from Nigeria, sir.
Hi. Hello.
Ahmad Shehu from Nigeria.
I can hear you, Ahmed.
Yes, sir. I have a question.
Hi. Yep.
Yes, I have seen some clinicians using sulfadimidine to treat an acute diarrhea in dogs. So I want to know if that is permissible in the practice.
What have you seen them use, sorry?
Yes, sir. I have seen some clinicians using sulfadimidine to treat acute diarrhea in dogs.
I would suggest it's not necessary. That the majority of cases of diarrhea are, and I have to be careful because lots of the data that I'm presenting today is based on studies performed in the UK and America. So maybe where you're working, but in my experience with acute diarrhea, antibiotics are not going to significantly reduce the duration of clinical signs. So I would try and avoid them and say we will use them if your pet doesn't get better in the next few days, or if it's systemically unwell. But otherwise, for me, with diarrhea, I would just be using a bland diet, so trying to keep them on something bland, and maybe some probiotics or something of that nature. I wouldn't be using antibiotics where I can avoid it.
Okay, thank you, sir.
Thank you.
Thank you, Ahmad. And Faye Angela, you are unmuted.
Hi, so I'm still a freshman student and my knowledge regarding this is still limited. I'm just curious if it is possible for an antibiotic resistant bacteria, it is possible to be reduced or eliminated, and how?
By removing that selection pressure. So multi-resistant bacteria will pay we believe that often they will pay a small cost for carrying those resistant genes. So they will actually be better off if they no longer have to maintain that resistance mechanism. So if you remove that selection pressure, if you stop exposing those bacterial populations to that antibiotic, it is likely that through natural evolution and the future generations will no longer carry that resistance mechanism. So if you stop using certain classes of antibiotic, you find that that resistance mechanism goes. A good example of this is with colistin use. So colistin is an antibiotic that's been used quite widely in the pig and poultry industries for a long, long time. But we've stopped using that antibiotic now, and since then, the levels of resistance to colistin have dropped dramatically, not just in the pig and poultry sectors, but also in people. So you can make those changes and you can get a lot of benefit from stopping using certain antibiotics. Does that answer your question?
I think she muted herself.
Okay. Okay.
Yes, yes. Thank you. Thank you so much.
You. No worries.
Yeah. And let's go through some more questions previously. So which antibiotic? So actually,
So that's quite a broad question that you're pointing to, question 5. And I would encourage people to download the Protect Me poster. We do have, each section is split up. I'm a specialist in internal medicine, but we had colleagues with a speciality in dermatology, orthopedics, ophthalmology, who contributed to this poster. So it has been set out by organ system, and we've not given just one antibiotic, we've given choices of antibiotic for specific ailments. So I would encourage you to download that resource and refer to that. We could be here quite a long time if I read them all out, and I think that it's worth referring to those tools that are out there. And the other one being the Danish antibiotic use guidelines, which is a significant PDF document, but one that answers a lot of those questions more thoroughly than I can do.
I see. And moving on to the next question, number 6, in viral diseases like parvovirus or canine distemper virus, antibiotic is supplemented. Is it the appropriate line of action?
So, very good question. Parvovirus in dogs causes a significant neutropenia, and often the neutrophil count can drop below 1 × 10⁹ per litre. In such cases, the patient may be at risk of secondary bacterial infection. So that's why you might use antibiotic in that condition. It's not to treat the parvovirus, obviously, it's to treat secondary bacterial involvement. I don't object to that. There is a lot of situations where the animal is not significantly myelosuppressed, where you may delay instigation of antibiotic therapy. So if their white blood cell is holding up, then I would concentrate on fluids and antiemetics. I wouldn't reach for antibiotics immediately. But if they were pyrexic, if they had a very low white blood cell and particular neutrophil count, then yes, I would start antibiotic therapy as well.
I see. And let's see. So what are your thoughts on emerging genetic technologies such as next generation sequencing to identify mutation leading to AMR or resistant internal environments, for example, competitive flora?
I think that's brilliant. And I think that as they become more widely available, we're going to become better, we'll understand them more and hopefully reach for them more. At the moment, I think these are really only available in the form of academic research. They do offer a fecal panel that you can send off to get an idea of the gut flora at the Texas GI lab, but I'm not sure how commercially viable lots of these sample techniques are. So at the moment, I think culture and sensitivity is the way that we're running and looking at making these decisions. I think that hopefully we will gain greater access to these new generation techniques, and that will improve our diagnostics and our antibiotic selection.
Cool, thank you. Let's move on to some of the audience. See. Eugene Wade.
Hello, actually, my name is Natalia. Thank you for the presentation. I specialize in neurology, nephrology, and I have a lot of cases like paralyzed dogs with recurrent UTI. And
right, yes.
Yes. And do you have some special secrets to prevent those incidents? Maybe would you advocate probiotics, prebiotics, demanose, and things like that?
Not really, no. We have a neurology department here and encounter this problem quite often as well. I think that we try to avoid antibiotic therapy for as long as we can, especially in the hospital environment, and we only treat them if they have lower urinary tract signs or signs of systemic involvement, because we will find a lot of these guys do develop bacteriuria, so they've got bacteria there, but they don't, it just seems it's a consequence of them having urine retention and ascending infections. If we can avoid treating them, then we have a better chance of clearing the infection later on when they're hopefully in a home environment and less exposed to multi-resistant nosocomials. So a delay approach is the best that we've got. In terms of the use of probiotics, are still a growing field, and I think it's a very exciting field. We don't yet have a good understanding of the vaginal or the urinary tract microflora. So repopulating it with appropriate bacteria remains a mystery. And I think that is an area of active research. I think there will be some developments coming online in the next few years. But at the moment, we don't offer that. And we really just focus on maintaining as well voided a bladder as we possibly can, either through manual bladder expression or the use of a sterilely placed urinary tract catheter. And we try and limit antibiotic use as much as possible because they do develop multi-resistance quite quickly.
Thank you.
Thank you. Fergus, I think we're running out of time, and would you like to stay and answer more questions, or would you like?
Yep, I'm happy to stay whenever there are, but please feel free to head off and do whatever other people need to do. I'll happily stay for a little while and keep answering questions if there are questions.
We will probably take another, probably 2 questions because we have received more than 200 questions.
Okay.
So I understand some of you may be disappointed. We realize every time we have a lot of questions unanswered, so we're currently thinking about ways to address that. But Fergus is kind enough to take probably another 2 questions.
Okay.
Yeah. Would you like to go through the list to see which would you like to?
Sorry. Yeah. AMR is increasing, and it's a real problem. What's that? So, I think question 16. I think this is an excellent question. We should. Antibiotic use is not the only part of this problem. You're exactly right. We do need to use vaccination. We do need to use hygiene, good hygiene control. One of the really interesting things that's come out of COVID is that people are washing their hands a lot more than they used to. And hospital-acquired infections, things like C. diff, which is a real common problem in certain hospitals, have dropped massively. So we're not seeing infections that we were seeing a little while ago. And it's not because COVID protects us, it's because the steps that we're taking to manage coronavirus have protected us against these things. So yes, antibiotic use and reducing antibiotic use is not the only aspect of controlling and helping tackle AMR, we also need to ensure good vaccination, good hygiene, and other good husbandry practice to limit our antibiotic use and limit this problem. And housing of calves is an example of that. If you house your calves effectively, then you don't develop calf pneumonia to anything like the extent that you do if you house them in small, overcrowded environments. So animal husbandry, very important way to contribute to reducing that. Would I suggest using antibiogram every time we use antibiotics? No. I think that there are instances where you can't get a sample. There are instances where you maybe have a strong index of suspicion. If I had a young coughing dog, for me, and the signs have been going on for 2 and a bit weeks, for me it's most likely Bordetella, and if the owner couldn't afford or didn't want to pursue a BAL, a lung wash, I would reach for doxycycline. I'd make an educated guess as to what we're likely dealing with. You don't have to do it, and sometimes it's not practical, so we wouldn't do it.
That's really informative. Thank you so much. And let's try one last one. Or yep, Dr. Raghu.
Yes, sir. Good evening, sir.
Hello.
Hello. Good evening, sir. Good evening.
Hi.
Sir, in most of the skin diseases, bacterial dermatitis, people are randomly using this cephalexin and cephaloxil. What is your opinion on this?
On the use of cephalexin for skin disease?
Most of the prescriptions we used to say that cephalexin and cephaloxil for the bacterial dermatitis. Though it is responding, and what is your opinion if we keep on prescribing this antibiotic continuously, will we going to meet this AMR in the skin disease?
I think we will. I think there's 2 aspects to that. Do we say we don't want to use a single antibiotic because we'll increase the resistance to that antibiotic, and therefore we should use a whole range of them? I wouldn't subscribe to that. I think that cephalexin is an appropriate first-line antimicrobial for skin disease. What I would recognize is that there are going to be some bacteria that do not respond to that, and it's recognizing those cases and saying, okay, I tried that, it hasn't worked, now I need to culture, and now I need to look at doing making an alternative choice. I think with skin disease, if you've got a superficial skin infection, a superficial dermatitis, try not to use systemic antibiotics. I think the guidelines are now saying really antibiotics should be reserved for deep pyodermas, not for superficial ones, because you can manage them topically, you can manage them with careful skin cleansing and antiseptics rather than antibiotics. So I would try and find ways not to use antibiotics where possible, but I don't object to using cephalexin as an appropriate first-line antibiotic, provided you're not expecting it to be for extended periods.
Thank you so much, Fergus. So, shall we stop here, or are you tired, Fergus?
No, I'm happy to carry on. If there's, it's a subject that I'm passionate about. So if people have got questions, I'm happy to answer those questions. But do feel free to leave as soon as they get bored and fed up.
we still got a couple of hundred people. They're not bored at all. but yeah, okay. So let's carry on.
Yep.
Yeah. Let's see who's next time. David RDDG.
Good day. Yes, sir. Can you hear me?
I can hear you. Yep.
So later previously in the class, you answered the question about antibiotic resistance in bacteria, that we should wait for their generation to expire so that it would not have an antibiotic resistance towards a specific case or so. So how long do we have to wait for such event to occur?
I'll just try and repeat your question to see if I've understood it correctly. Are you asking how long I would have to hold off using an antibiotic before I would expect a resistant population to become sensitive to that antibiotic again?
Yes, sir.
I think that's a great question, and one that I don't think we've got the answer to. Earlier on, I answered a question from Faye, I think, that I said, well, it will happen because there is a slight evolutionary cost to antimicrobial resistance. Unfortunately, there are some instances where that cost is low, and the resistance mechanism may persist in that population of bacteria for a long time. So I think it's going to be a very variable. It's how long is a piece of string, really. I think that it's still nice to hold off using an antibiotic if you feel that there is a high incidence of resistance, and you will get improvements. But if we take the example of colistin, it was, I think, over about a decade that they saw significant improvement. So they stopped using that antibiotic, and then it was a significant time later that it became, the resistance levels dropped significantly.
Thank you. So that means there is no way of treating that an animal, that there's no way of waiting it out in an animal. Like a treatment for the antibiotic resistant bacteria.
I'm sorry, I couldn't quite make out that question.
Oh,
Okay.
yeah, I think David, we can't hear you clearly.
Okay.
But thank you so much for your question. That was a brilliant question. I think we're gonna officially stop here, okay. And we're gonna close up the event. Let me just let me just share this PowerPoint. Yep. So thank you so much, Fergus, for your brilliant talk. That was really useful. I'm sure the audience really love it so much. And so everybody, as you already know, that the after the lecture, we'll have a little task for you. So this is the actual coursework computation. So you're all invited to read a little bit summary of what you have learned today, and what impact has made to your study, what further study you have planned. Oh, I think that was this one was not part of this one, the part of this. And you can check out this website at the x-well.com/coursework for more details. So you can submit your summary, and after that we will select 10 best courseworks, which will then you will receive a little a best coursework award. So I look forward to see it. And okay, and let me pass it.
Thank you very much, Fergus. Although we still have like more than 200 questions waiting, but due to time, we really can't answer all of them. We're thinking about ways to address that. But thank you very much for everyone who support us. And as we mentioned, you can reach us through this contact information. And also, if you have any good suggestions for the future topic, please let us know. And Fergus also mentioned that he's willing to probably in the future to join us in the future. So very welcome. So thank you very much, everyone. Wish you all the best. Should we take 15 seconds to say thank you? Should they, yeah, unmute everyone to show our appreciation to Fergus.
Thank you.
Here, everyone, say thank you to Fergus.
Thank you.
Thank you so much.
Thank you so much.
Thank you so much.
Thank you.
Beautiful one.
Thank you so much.
Again.
Thank you so much.
Yeah, get greetings from Kenya. From Kenya.
Thank you very much indeed. Thank you for joining in. I have put the Protect Me poster on LinkedIn if you want it. There we go. But thank you very much indeed for listening.
I've enabled the chat. I've enabled the chat so everybody, if you want to stay to leave any more questions, please feel free to do so. And the event is officially stopped here, and we hope you enjoyed it, and we'll see you next time. So we organize these events regularly, so please make sure to check out the website xval.com/events to visit more. So thank you again, everybody. We'll see you next time.
Bye. Thank you. Take care.
Bye. Thanks. Bye.